and I will introduce myself. My name is Shoshana Helfenbaum, and I am a clinician as a social worker, which brings me to my connection with Esme Fuller Thompson, which goes back many years. And also her advice to not pursue a regular PhD program, but to do a practical PhD that would involve bringing my practice experience into the work. So it was actually at her suggestion that I started this doctoral work, which came out of my practice as an educator. So I'm an educator who works with teams in the geriatric world and in long-term care specifically over the last little while. I also have a practice as a psychotherapist, and I am a consultant in mental health for companies such as TELUS Health and Bell Canada and so on in the space of wellness. And one of my most important missions in my work is to help people bring compassion to the interactions they have, because most people who come into the space of healthcare are there because they want to make a difference. They're there because they care about what they're doing. And then what happens is sometimes distress comes into play, where people have something they hope to be able to do, but in real life, when there's conflict or when there's lack or when there's transition, people can experience stress, which affects how they work in those interactions. So my research centered on that topic. So I'm happy to start the slideshow now. And when we pull up the title, I'm just going to take a moment as we pull it up and ask people to introduce themselves in the chat. Perhaps your name and one word that you associate with healthcare. So let's have a look at the chat and see what's going on in there. Your name and one word you associate with healthcare. Nicole, hi Nicole, says hope. Reina, vulnerability. Resilience, confusion, amaze, connection, frustrating, stress. Okay, so for those of you who like to make connections, to use Bill's word, what do you see among those words that is and help? Can you see, all of you, that there's a wide variety of experiences that come into play when I ask the question, what's one word you associate with healthcare? We have the negative to the positive to the illusions, amaze. So can you all suggest some themes that are coming up in those words? Relationships, a dialogue or lack thereof. Relational. Who paid you guys to say these things? Need and fear and help and appreciation. Need, fear, help, appreciation, diversity of needs. Thank you. I'm going to work with Margot's phrase right now, collaboration. Thank you. I'm going to use Margot's phrase as a launch pad here for a moment. Spectrum, right? So there's many different experiences that people bring into healthcare, which happens by definition as an interaction, right? Mm-hmm. So the question is, when there's a need, when there's a maze, when there's complexity, when there is a need for help and stress, the interactions that happen are affected, are they not? They take on a certain, So what we just did was take a group of people many of whom never met one another before, and we asked them to come together on the basis of having their own personal experience. So this study is the same thing. You just did a microcosm of what I do on a larger scale, and what I'm going to suggest all of you can do in your own practice or personal setting. which is to understand that there's a need to pay attention to the relational interactions that are happening that actually compose together as a group or as a set of interactions, a relationship in healthcare, a relationship in education, in psychology, in business, and especially in anything to do with aging. And I'll tell you why. Because if you are a person who is 80, you have had more experiences than a person who is 10. That is mathematically true, is it not? Give me thumbs up if you agree with what I just said. Okay, so you arrive in all of the things you do as the course of aging takes place with a set of experiences. So if you're going to change or improve an interaction with people who are in the process of aging, which is all of us, and especially people who are in the process of aging who have more accumulated experience, you need to pay attention to who they are and who they are as they arrive in the interaction with you and who you are. So that's the backdrop. And I'm going to tell you a little story about what happened. So let's carry on, please, Yulia. Thank you. So this is a picture of, for those of you who know, my esteemed colleague Daniel on the left, and a group of team members at a wonderful long-term care home who, actually it's Brampton Extendicare. And if you look carefully over the TV in the background, you'll see ... a peaceful and joyous place to live and work. That's their mission statement. That's me in the back leaning against the table with the red shirt on. And this is a variety of people who gave me a variety of backgrounds and experiences when we started our day. So the subject of this research was a course that I created called Engaging Families in Care. A tiny bit of history to give you context. I was brought onto a team at Baycrest Center for Research Innovation in learning, research, and innovation in long-term care. And it was the Ministry of Health and Long-Term Care at the time that said, we have a need for teams to learn how to bring families into care. Now, think about that for one moment. The context is that with many people living in long-term care, also living with dementia and other cognitive impairment, who they are is a composite of what they can express to you and what other people who know them as persons and not just their condition can offer into the circle of care. So this particular education became shaped by my research into how do you actually overcome the very different needs that the different groups are coming with. Leadership is telling me we need education that's going to make staff bring families into care interactions. Staff were telling me, please help us deal with difficult families, help us stay safe from families in distress. And the families were saying, please help us have better interactions because we arrive at these interactions in distress and we need help, but we don't want our emotional turmoil to destroy our relationships with direct care providers or staff. So what I discovered was a type of education called relational education through the Taos Institute. And what are the tenets of it? According to Don Dole, who just published a brilliant chapter on this last year on what relational education pedagogy is, it's collaborative, it's appreciative, and it's experiential. So if you've advanced the slides, I'll tell you more about it. Yulia, could you push? Yeah, thank you. All right. So this research was informed by social constructionist methodology, which is that relational processes are involved in whatever you do. And so the purpose was to understand the influence of the education on team care practices. The second purpose was to use the findings about what was happening in relationship to one another to improve healthcare education and facilitation and research methodology. And if you take a look, you'll see that the research approaches here are that there's many voices, there needs to be transparency, that we need to crystallize different ideas rather than find something that's generalized, because we're in one context and we can crystallize ideas, but we can't say that everybody in every place is going to be the same, and so on. So the next slide, please, Yulia. So here are the results. I did in-depth grounded methodology interviews, and I worked with 13 different people who were different roles on the team, different disciplines. So there were nurses, there were personal support workers, there were recreational people, there were leaders, administrators, social workers, dietary people. And we went in depth about what their experiences were of using the relational education that really focused on interactions in the education and how they can translate into practice, and what their experience of using the education was on their practice. So did it influence their practice? Yes, no, and how? And here are the results. These 6 hexagons here show you what I'm so grateful ended up being the results, that people found that the education helped them include one another more. They had experienced an increase in well-being, and that ran the gamut from people. Here, I'm just going to look at some of the things that people said quickly. An increased well-being was associated with not feeling alone, for example, having more ability to be more patient, connecting with others, had to do with relating versus controlling. So a lot of people will say, let's manage the family. And this became, let's relate to the family. Helping one another, respecting each other, appreciating each other, being calm versus being in conflict. Another hexagon on here that I'll talk about, becoming more receptive to one another. So this is a very big finding. Why? Because when people are closed, because the distress they've experienced in the past shuts down their ability, whether it's neurological, I see you coming and I've had trauma, and I have spoken to many people who literally described running for the nearest closet and locking themselves in a closet when they saw particular families coming, because those families signaled being yelled at and whatever the case may be. So becoming more receptive happened when the relational education taught people experientially, we can appreciate you for who you are. We can teach you to have more of an emotional regulation, higher emotional intelligence, right? Meaning that the refractory period between you receiving a person in distress and being able to respond out of choice and not reaction was diminished. So what that means is if I see a family in distress, I have a whole new set of tools that help me be more receptive to what you're going through because I'm not taking it personally. Exploring new possibilities was a big one. Well, we could try something new, because what did we do at the beginning of this session together, right? We spent just a moment saying, what's your experience? What are we all arriving with? And we explored something new. We came up with a language for this particular group in this time and place that was so brilliant. We tried something new. What are some of the things they said? Seeking practical applications of how to put learning into practice, developing new feelings for one another. So there was really an appreciation that it's very hard for families to arrive, to transition, and they need a lot of patience, and that we can also understand that when people go through grief reactions, part of that is having an emotional outburst for some people. Part of it is actually isolating themselves. So if somebody walks, a big thing people would say is, you know, I take care of these people's relatives all day, and when they see me in the hall, they don't even say hello. Well, that can be a grief reaction where people just close down and shut other people out. Reflecting deeply is the last one that I'll talk about, which was stepping back and slowing down, were some of the words people use, which I just feel so happy talking about it. Isn't it amazing that people could stop for a minute and sit back and say, what just happened? What could I do to bring out the best in this situation? So I'm going to ask for the next slide. And the purpose of grounded research is to actually come up with a theory That was the purpose, to understand something that's never been understood before. So the theory was happening on so many different levels. There was the co-design with my colleagues. There was the relational leadership, where I was doing coaching of teams and learning from them and asking them what matters most to you and what's it going to look like when we do educational implementation of this program. How do you want it to play out? What are the things that are so important to you that we need to reinforce those? There were the sessions themselves. There was the team practice that was happening after the sessions and the interactions with family. And I want to share a beautiful story. And of course, the research process that held it all. I'll share one story with you. There was a woman who was in the class with me, learning with me and teaching me, who said to me when I came back to interview her, you know what happened? There was a man who was living here and he was just dying. He was in his last few days. So we called the daughter and we told her that. And she had been very distant. She had been disengaged. She hadn't come in a lot. And she came in and she had a very difficult relationship with her father. So she was sitting in the room and I came in and she looked at me and I saw in her eyes how difficult it was for her. So I sat down with her and I said, I have a few minutes. Do you want to talk? Can I get you a drink? Would you like some tea? What do you like to drink? And everything changed. She said her shoulders slumped. She just sat quietly and she softened. And she said, yes, I'd like that. And so I got her tea and I just said to her, what you're doing is wonderful. It's going to be good for everybody. And your father really cared about you, even though he couldn't show you all the time. So why don't you just sit here with him and hold his hand? It will mean so much to both of you. She said, it was wonderful. I felt so good when I left. I said, wow, I did something special there that I might not have done before, even though I wanted to. I might not have known how. This is the most amazing part. She went home, and when she came back the next morning, the daughter was sitting in the same chair, holding her father's hand 16 hours later. And she stayed with him until he passed away that day. So that's why the family interactions are included here, because the influence extended in circles, in concentric circles, beyond us thinking at a desk, what's best practice? What should we include in this? It flourished into something more. So please go ahead, Yulia, go to the next slide. So here is the theory. Very exciting. A theory came out of this that was really garnered through 6 years of research, which is experiencing the relational education framework in this study positively influenced the receptivity of team members to one another, the exploration of new possibilities for connected, inclusive, and reflective ways of engaging in long-term care, team, education, and practice, while increasing the team members' experience of well-being in themselves and others. Now, for those of you who had a little snicker that that's a run-on sentence, I think when you study for 6 years, you're allowed to have one run-on sentence. That's your theory. So there. Anyway, next slide, please. All right, so what are the implications from this work? That there is progress in elucidating or making clear or bringing to light what long-term care relational processes are. Second, there's progress in articulating how to facilitate in a way that increases cohesion and trust on teams in long-term care. And thirdly, there's progress in creating research, educational, and practice tools or methods for using relational processes in team healthcare. Now, I would like to go to the next slide, please, Yulia. And actually go back, please. Yeah, I just wanted to check if you can go back a moment. All right, so I'd like to stop here and turn off the slides and see where everyone's interest is, because I said some pretty big things. And maybe you want to ask questions. Maybe you'd like to know, what are those tools? Maybe you want to know more about what happened, but I don't know who's in the room. So I'd like to gear this next part toward what is most meaningful to you. So please let me know. What would be of interest to you? Carly, I see you speaking, but I can't hear you.
Please
It's
unmute
not
yourself.
Carly, it's Rhonda. And
Oh, hi,
I haven't
Rhonda.
figured out how to take off
Oh,
my new daughter-in-law's name, but she'll be here soon. Shoshana. What I'm interested in mostly because I am a registered nurse and I haven't really worked for many years, but I've been, in the background healthcare system in Toronto from having come from, San Francisco Bay Area, UCSF, Stanford, that whole environment. And Shoshana, that we've had many circles that has brought us to this point today. Because the Canadian healthcare system is, it's not falling apart, it fell apart. And, it's not funny because right now the people that are most vulnerable really need it the most. And so I'm so excited that people like you and other people are going to be building up these spaces because, and it's really necessary. So I'm coming from a very team approach. Without the team, there's burnout. And, I came from a unit in San Francisco where I kind of got imported to this beautiful city and, have been very privileged over many years, but it was like, I always say it was like going back 200 years in nursing. But now I have, incredible hope because there's a lot of transformation and these spaces, these have changed rapidly because of telemedicine. So I'm just grateful that Shoshana, you have the energy for this and, for the team approach to build it up from the ground up in an academic, in a very legitimate way, because the voices now of truth are going to start rising, which are really, about what healthcare is. It's about caring for each other. And it's about the circle of care. And I love the circles of care because, this is a new innovative space. And what is very hopeful is, thank God, the next generation that's very digital is understanding that Canada and many spaces need to move forward very rapidly in this. So I'm really, took time out of my day, which this is very important to me, to support you, Shoshana. And I think there's another Rhonda on this line too, Rhonda Hecht, shout out. Because, this too shall pass and we're in transformative times, and the energy of love and care, which really, is through a group approach, a team approach. And I guess I'll just end it by saying, I'm looking at the arc of my husband, thank God, very, long career that I've seen many changes in he's cardiologist, many changes in his practice. And we met in San Francisco in 1988 when I went to nursing school. So I've seen enough of these times go around that I don't feel despair. I feel hope because right now, people like you are engaging in these spaces in a way that's, with the concentric circles and the caring, because otherwise the house of cards falls down. And it's not falling down because, here we are, the change so, thank God. And my children now decided, unlike their parents, to not go into, the service doctor, nurse, they're in these innovative spaces. So afterwards, you have to talk to my daughter, Maya, who's coming back. Anyways, these things are growing, the circles are growing and it's elevating. And I'm grateful to be here to see people like you doing it in a legitimate way because the science supports it.
thank you.
Thank you.
Thank you so much. So Rhonda has a very clear message that I'm hearing from you.
From nursing, I'm coming from a nursing message.
From a nursing message, which
and
is,
I was working also, I was back
emphasize the
working,
care,
I was re-engaging in nursing, by the way, in Mount Sinai, just so you know. And then I left, I had a job that lined up at Mount Sinai for the beginning of the pandemic. And I decided right away in labor and delivery and all the stuff, I'll have to catch up with you. But immediately when all of this happened, I pulled out and I know what's going on behind the scenes and it's not good for the people that are really caretaking if the caretakers are sick, then we need to elevate that. Exactly. So that's my message.
So
thank you so much, Shoshana.
Thank you. So this work, why did we title it Compassion? Teaching Compassion?
I didn't even have a chance to look at it, but yeah,
is because compassion is and I'll add this now so that we can hear from other people as well. But you really bring up the importance of compassion, It wasn't a word that I started with, but the results, and I didn't go into depth about the discussion here, the results showed clearly that it was people's ability to transform the distress into something that they could express concern, caring into. And we know from the latest research in neuropsychology that there are different brain centers. When you
Absolutely.
experience empathy and you actually resonate with a person's pain, that experience goes into the pain centers. When you experience having love for another person or care or concern, it goes into the reward centers. So it means that teaching people who are working in long-term care in the field of aging, where they're there because they have comorbidities and several different health conditions that force them to need care 24 hours a day.
Definitely.
And so at that point in time, if I can experience that with compassion, I'm going to feel healthier and I'm going to be better off. So thank
And
you.
it's also a joint space,
Thank you
Shoshana.
so
It's a
much,
joint
Sandra.
space.
I want to
Yeah,
give
continue. I'm
others.
going to continue. I'm going to actually get off of the screen because I have to go, but I'm
Okay.
going to listen to this, but I jumped on because you're changing lives. I'm going to listen to about 5 more minutes and
Okay.
listen to it again. So
Enjoy.
compassion, the roots
Enjoy.
of empathy. Absolutely.
Thank you. Okay, so I want to invite other people, whether that's Dr. Cohen, Joy, Margot, Lena. I see also that Elise is on, Jason's on, Bill, Lena, Colleen, Raina, and Nicole. Would anyone else like to ask a question in terms of me expanding what yeah, Margot, please go ahead.
Please.
Margot, please go ahead.
Okay, I come from a different perspective because now I'm from people who are alone, who are isolated, and actually supporting those who are caring for them or those who are dying.
Yes.
So it's a little different perspective. Either they're waiting for long-term care or they don't want to go into long-term care because they don't feel comfortable doing that, or they've promised their spouse that they would never put them into care. And yet they themselves are now suffering physically and mentally. And it's, they really do have similar needs, but there doesn't seem to be a lot of support. You can get caregivers coming in to do some physical things with them, but no one's there for them emotionally. And that's where, if I can help to do this or that, but many of them are not computer literate or don't have computers. And I know it seems impossible, somebody in Toronto saying, you don't have a computer. Hey, I just got my first interactive cell phone and I still haven't figured out how to swipe or to change the screen. Yeah, we're learning, but the point is there is this other sort of parallel universe of care need that doesn't get addressed.
Margot, I can't tell you how glad I am that you raised that, because the reason that I'm able to teach teams to have compassion for families is because the caregivers themselves, whether it's friends or whomever, family is a generic term for someone who matters in the life of someone else. Okay, it's not a blood relation. They don't have the means to, they don't necessarily have the emotional skills to regulate their own emotions. They don't have the support to know that if they take one step, they'll be supported for another 2 or 3. They may not know. And that's why in my private life, I support caregivers in particular. And one of the things that I've decided to do, which is very important to me, is to actually make information on wellness and health and well-being available to caregivers, so that maybe they just have never seen all of the tools that are out there, but people need a toolbox. They really do. They need a toolbox and they need support. So with your permission, I'd like to speak to you afterwards and see what it is that I can do to support the work that you do.
Certainly.
Yeah, thank you. Who else would like to ask a question? And it's not just a question. Is there something in particular that interested you in what we said or in your own experience?
Hi.
Hi. Hi.
I think what you're doing is amazing. there's so much support needed in this field. It's not easy to support difficult situations like this. And so kudos for bringing it to the forefront and really paying attention to this needed topic. My question is, how do you encourage people to stay curious and passionate while in this process of long-term care, which can be draining? And I heard you say you are moving towards getting caretakers mental health support because it can be very draining, but it's almost like they need to be celebrated to stay passionate. And yeah, so I'm just putting that forward. How do you keep curiosity for open for the patients or the people who need the care themselves? And how do you keep the caretakers inspired and passionate?
Thank you for your question. Of course, it's a billion-dollar question, not a million-dollar question that I can't answer. I can tell you that what relates to that from my research, what I did learn, is that having people rehearse in safety what it's like to be in a situation where they bring out the best in an interaction is very inspiring. So being able to say to, okay, so I'm going to explain that there isn't a particular model that I developed for this research called the ARC model. And it's a simple communication tool, which A stands for acknowledge, R stands for reassure, and C stands for clarify. And I made it to be simple because it had to be very easily accessible. However, it's based on mindfulness. It's based on the heart, the Cleveland Heart Clinic. It's based on many, many models. What it says is, when I'm in front of you and you come to me, how can I acknowledge your experience, whether that's validating, mirroring, nodding, just listening? How can I reassure you that what matters to you matters to me? And that's appreciation, right? That's really appreciating another person, is to say to them, your concern is my concern. I want to help. All of that to connect to one another. And the third thing, clarifying, is to actually get clear about what the person who came to you thinks is the next step to move the situation forward. It's a very powerful experience in real time to take a person who is very upset, really truly upset, and going through physical. Margot also mentioned physical strain, not just emotional, right? The physical toll. And what it means to live in the moral distress of knowing that you promised somebody, you made a commitment before you understood that you might not have the capacity to keep that commitment. And so now there's moral distress. If I continue on this situation, I'm reducing my own health. And if I don't continue on this situation, I'm breaking a commitment I made. So there are people living like that. And when they come in front of you, how could you not be curious if you've had a personal interaction in an education session where you meet someone in role, or someone who's what we call a simulated participant, where they're pretending or emulating the experience of a person in real life, who has this richness, who can say to you, this is my situation. And you're in a safe rehearsal space, so you can get curious. And then you have an experience one time of being curious, you're appreciated by the people around you, and you're valued for what you're doing. It becomes much easier to translate that interactivity into real life practice. And then once those relationships get stronger and more appreciative in nature, that itself becomes rewarding. So now we're in a positive cycle rather than a downward spiral. So I can only answer that question from the perspective of my research experience and my practice experience. Does that speak to you?
Yeah, it makes a lot of sense. And that actually, and it's inspiring to know that that can be the future of the healthcare, that people have that support and the training, and they feel good within themselves to take it on.
I hope so. Thank you. Would someone else like to ask a question?
You may have just answered my question. First of all, I have to echo everyone else here and say this is much needed work and thank you.
Thank
As someone who's not really part of the healthcare system, I have to acknowledge that the healthcare system is very complicated because you have different systems and ecosystems going on. You have governmental regulations, you have the institution itself, you have the aspect of the caregiver and the patient and stuff like that. And so my question is given that, if I were to walk away with one thing I could implement today, would it be ARC, or what would be the first baby step towards making that change within a system?
So you as a healthcare consumer asking what one thing you could action to improve the system in your micro interactions, is that the question?
I guess the question is, what is one thing that all parties could in theory do? Like, what could an institution implement as its first step that would that would enhance all of its relationships, all its stakeholders, and all the people involved?
Okay,
Based on,
I can give you one thing to do. That doesn't mean it's easy, but I'm going to give you one thing because I heard your question carefully and I'm holding you to it. That one thing is to learn the skill of compassion. And I said that very carefully, to learn the skill of compassion. What I learned in this process is that compassion can be taught, and it's a skill to actually stop when things are distressing and turn inward and say, what can I do right now to support myself? Because I'm being asked to be in a difficult situation. What is it I need? And it can be one breath. It can be one breath where I just breathe in and say, am I okay to continue right now? And do I have what I need? Can I say to the person in front of me, I really want to talk to you. I'm just going to get a drink and come right back. What is it that I can do to set myself up for success in the interactions which become the system? Having said that, there are many things constructed into the system on a policy level, on a structural level, that actually do not support this type of approach. One of the reasons that I jumped into this research is because long-term care is by definition compliance driven. And what I mean by that is that if you want to protect the most vulnerable people in our society, arguably the most vulnerable people in our society, what are you going to do? You're going to make a regulation. Make sure these people eat 3 times a day. Don't just give a license to someone to open up a long-term care facility. You need to make sure people have a bath. You need to make sure people eat, that they have this, they have this, they have this. By the time you add up all the thises, you come to a huge complex. The Long-Term Care Act is one of the most complex acts in healthcare because they're trying to make sure people are okay. However, the flip side of that is that if I'm working in that system, I'm ticking boxes all day and I can become very task oriented instead of relationally based. So I come along to say to people, actually, you don't have to take more time. It doesn't have to be draining to learn to do this. It will create a flow in what you do, and a coherence and a collaboration in the approach will make everything else you do easier. So I just wanted to add that in, is that when you say to change a system, it's happening structurally in policy, and it's happening in the relationships as well. So thank you for your question.
Lena,
Thank
you had your hand up, right?
Yes, thank you. Thank you, Shoshana. This has been wonderful, really exciting
Thank
to
you.
hear about this. I have kind of 2 reactions with different hats on. One is that I've not heard the phrase relational education before, and I love it, and I'm gonna look into it. I think I've had, an intuition as I work with students in a clergy context. My sense is that the relationship is more important than the content, but I'd love to hear, what actual research and, people put that out. So that's one thing. Thank you for that. And then the other piece is, I guess, both specific and general, like, are you available for trainings, or are there people, teaching this? My parents are both in a life care facility, and I have such, such feeling for the people who run that place and what, what I think they really care. And I think it's really, really hard. And, would love to see how they can just feel more supported in the work that they do.
Yeah. Thank you so much for sharing that perspective. And I'm very happy that we have different people coming to this work with different backgrounds, right? Rhonda, who's in healthcare and she cares about it for many years. We have Joy, who's on the call as a consumer, longtime consumer of healthcare with aging parents. We have Margot, who gave her perspective. And now we hear from you, who are representing someone who's teaching clergy and also living with the role of supporting aging parents and wanting to support the teams that work with them. So absolutely, there has to be a way to provide that support. And I'm going to get to that in the next slide, actually. So yeah, thank you. Oh, there's slides left. Maybe we should go on to that. I just want to take 5 more minutes and offer perhaps Raina or Bill. Okay, so go to the next slide, Yulia, and then we'll go back to the group. So what are the contributions that this research shows? That we should find a way. This is what I would like to do. I would like to actually overcome the barrier of psychological safety. And it's a little bit tricky when you think about what it would mean for a team to sit in an education session with the very families that they've had experience with in distress. But it has to be done, because we have to come at this as a team, all on the same side. So I'm going to try that in my next phase of practice, if I'm able to. COVID has changed a lot. So there's less of an appetite for in-person in terms of what's being funded. However, where there's a will, there's a way. The second thing is to actually use the education processes that I uncovered or elucidated in remote learning. So what did we do today? Right? We started off with, let's all talk about one way that we all relate to one thing. So we made coherence and did something to bring together people in different places virtually. So there still needs to be more done to understand exactly how to deliver and the format that would work in terms of these types of safe rehearsals I was talking about. And also to support a growth orientation toward dementia care. What I mean by that is that when a person is in decline, physically speaking and cognitively speaking, people can still see it as an opportunity for growth and transformation. And some of the beautiful work of Leahy and Wright and nurses who have been writing about this, in particular, Wright's was talking about softening, illness, suffering. Those are 3 words that mean a lot: softening, illness, suffering. What it means is that you can have a transformation as someone who is a family supporting someone through death and dying in long-term care that is actually a growth experience and not only a death experience. And that's something that was borne out in the research. So I'm very interested in that. So let's look at the next slide, please. And I think that's a personal note, which is which way should we go? So please carry on, Yulia. So what does it mean for all of us to be an agent for positive change? We can try to empower freedom of choice. And that means that when I'm in a situation that's distressing to me as a healthcare provider or as a family caregiver or as anyone else, I can try to do things for myself to build skills that empower my freedom to respond in the way I choose. How can I become more resilient? How can I have a more positive stress response? How can I turn to the people I'm in distress with, rather than turn away, disconnect, isolate, and cause conflict? And the second thing that's very important for all of us to do is build that relational toolbox. And for me, that would become an agent of exposing teams to relational processes. And yes, I have not built out what that looks like in my private consulting business. And I'm here today as a staff member in an academic teaching hospital, but you bet I'm thinking about it. And as much as I can do it, as much as there's still an appetite for it and funding for it, I'll also do it in my work context. And again, offering safe rehearsal and coaching and building organizational capacity, because if you teach a team how to do this, but leaders do not appreciate it, or support it or reinforce it or reward it or monitor it, it's going to have about 15% uptake. If you teach a team how to do this, but before you do that, you talk to the leaders and say, what's one thing you really want me to make sure that we cover and or succeed in applying to practice, then do the training and then coach on that one thing after the training for a while, you will get 85% or more uptake in terms of practice change. Next slide, please. Now, this is a quote that comes from Psalms, and I thought it was really interesting. If you translate it, it says, how good and pleasant it is to sit as sisters and brothers, also together. Why did I use this quote? Because when I thought about what I was going to do in my actual dissertation defense, I thought, well, I'm going to have to sing a song or do something that's a little bit out of the box because otherwise it's not me. So I thought maybe I'll sing a song, but better than that is a quote from a song. And look at the words. We're sitting together, but we're also together. How good and pleasant is it to sit as sisters and brothers, also together. So what is that teaching us? That the person who wrote this psalm was acknowledging that we can sit together, but not be together. So I'm asking all of us to make an effort and to be conscious of what it means to not only be in the same space in healthcare together, where we happen to be there, but to make an effort to be in it together. So please take down my information. Please get in touch with me if you have questions and would like to know more about what it could look like to support the people you're with. And maybe we stop sharing the screen and see if there's time for a few more questions. We have 10 more minutes. So who else would like to direct our conversation now based on something that's of interest and experience to you? Or maybe you want to share what brought you here, actually. Please go ahead.
Hi there. This is very relevant and wonderful information. I'm a social worker. I've worked in acute care for most of my career, primarily with an interest in geriatrics. And my colleague, we just started a private practice about 6 months ago, specifically with this niche in mind, because she was in long-term care and I was in acute care. And we found that it was a real challenge in terms of trying to be able to support people within the framework of, for instance, in acute care, very quick turnaround times. And as you said, it's very task oriented, right? It's like people have to get treated, they have to move on, So we just felt that we wanted to be able to do a shared practice together. And that's what we do. And we've called it Connected, because we feel very important that connecting with patients, with older patients, older people, is a way of showing compassion and support. So I saw this on my research that I was doing, and so that's why I'm here. But you had asked me before what brought me here.
I'm so glad. Please reach out, okay? Because I'd like very much to collaborate with you and hear about your exciting work.
Absolutely. Thank you.
Well, Shoshana, can you hear me?
Yes.
Beautiful work. Thank you so much. And I think what you're doing has helped me distill what's most valuable for me in making and participating in community, some core commitments. One,
Bill, can you speak a little louder, please?
Yep.
Thank you.
One value commitment that came up is a desire to flatten expertise and to distribute expertise and create new knowledge. And the model certainly evokes that. Also to stay in a curious position, with those we are working and living and abiding with, so that dissolves assumptions, because we in healthcare, we try to get through the day with our assumptions, and often they're not exactly on target because we're listening mostly to ourselves or involved in one or two dyads. And to open up larger space, I think, helps us to move past those assumptions. And what else? Let's see. Well, the other remains the other. A person that we can never know, really. If we can't really know ourselves, how can we expect to know another person? So staying in a curious position enables us to create a language that helps us learn new knowledge about one another. So that's basically it. Just distilled values that are important to me. So thank you.
I'm so glad. I'm so glad. I'm so glad. And I think you helped me just now also to remember why we added the element that there's research into mirror neurons that's becoming clearer. It was an idea a few years ago, and now it's getting clearer. And the work of Dan Siegel, who does interpersonal neurobiology. It's a big mouthful. But what he says is that biologically, if you don't show yourself empathy first, you can't actually offer it to someone else to the same degree, not even close. So we actually have to start turned inward. And at first, when I first presented the model of ARC, I said, we're going to do self-ARC, then like family ARC, then team ARC. And people, this is 2015 originally, 2016, and there was no appetite for people being taught how to talk to themselves. It was seen as something very strange, unwelcome, and really, it was snuffed. It was snuffed at first. But as time has gone by and mindfulness and other things have become more popularized, the science has caught up to the practice, and people know that they need to check in with themselves. It's not strange anymore. So thank you for reminding me that this work came out of that. It came out of being a little bit courageous to say, I'm sorry, but I can't ignore that science. We actually have to pay attention to what's going on inside if we expect teams to feel well. Well, thank you so much for that comment. And it's a pleasure to hear your learning. I hope, did anyone else learn something about themselves today? Please feel free to put it in the chat. I'd love to share it. If you had an aha moment, and if there's anything else that I can support you in your own important work and life, right? Because Margot's work is her life. And for many of us, there's a blur. I have the privilege of caring for aging parents as well. And it's really a privilege.
Shoshana, is it okay if I could I put your contact in the chat, because I took down that slide?
Yes,
would you?
Sure,
Yeah.
sure.
It'll come off.
So a personal thank you without, I'm chuckling because I'm not on my own computer, so that's not a picture of me, but I wrote, everyone brings so much to this. Thank you for being my teachers today. And I wrote that because I knew that selfishly, it was important for me to keep the slides to 20 minutes and be able to learn from each and every one of you. So I'm very, very grateful for your participation today, and a big acknowledgement to my supervisors for this research, Dr. Sally St. George, and to Ciliani, Dr. Peter Whitehouse, Dr. Ciliani, Camilla Borges, Dr. Sheila McNamee, to my family, to my colleagues, Raquel Meyer, Dr. Raquel Meyer, and Daniel Galassier, who were instrumental in developing and teaching this with me, Dr. Kathy Smith, who was also a partner in crime, to the Center for Life Course and Aging, to Esme and to Yulia and to Nina, who helped prepare me for today and invited me to be here. And I hope we can continue the conversation.
Thank you so much, Shoshana, for your talk. This was really great. I've put a bunch of links in the chat, and among them the evaluation link, and also some links to keep an eye on for future seminars, and some Institute workshops that are coming up that might be of interest. So thank you, everybody.
Thank you. Please
for
do the
joining us.
evaluations. I'll be watching closely for the feedback anonymously. It's very important to me to use this to improve also. Thank you.
Thank
Bye
you,
for now.
everyone. Bye.
Thank you. Thank you.
Bye.
Bye for now. Thank you for coming.